before I get into different slides, I'm going to tell the backstory on why I'm doing this talk one more time, because I did this last year as well. I did a talk in reaction to the NAEMSP Position Statement. And for people, a lot of different folks have signed up from various parts of the world. NAEMSP is in the US, National Association of Emergency Medical Services Physicians. So a little bit over a year ago, there was a meta-analysis that looked into all the different papers associated with traction splints. Not all of them, but quite a few of them. And it led to a position statement that wasn't very favorable towards traction splints. The papers, frankly, did not have an awful lot related to Slishman Traction Splints. And so I wrote to the NAEMSP, wrote to the lead author. He was very kind. He said, look, I think your traction splints have a lot to offer. I've used them myself. You need more literature. And so I wish today, a year later, I had a mountain of literature to share with you, but I don't. I do have more perspectives to talk about, more thoughts on different devices. This is not an exact repeat of last year's talk. For anybody who attended last year, this is slightly different. I'm going to talk about the NAEMSP paper, but I'm also going to talk about, what is evidence in terms of evidence-based medicine, and talk about other types of devices as well. What really triggered me doing this, I've done quite a few different trade shows in the past few months. And at one of them, a firefighter walked by me and he just said, yeah, we aren't using traction splints anymore. And then I went to an athletic trainer conference, and one of the ER doc speakers put up a slide, and it had a Sager, a Hare, and a Kendrick traction splint as examples of things we used to use. And so I told my wife Vanessa, and she said, we have to repeat this webinar. You have to speak your truths. And so here I am, speaking my truths. So do traction splints still matter? If you decide to only stay on for the first minute, the answer is yes. Does pain matter? The answer is yes. All right, so moving to the next slide here. Things that we're going to go over, I will split hairs on the NAEMSP position statement. We'll talk about static versus traction splinting, what I call life-saving versus life-improving. And then we'll go into all the different contraindications with traction splints, and why we even say midshaft femur fracture. Why is that a thing? Why do we care even that it's a midshaft femur? We'll go into the differences between legacy traction splints and STSs, and then how I view management of the multi-mangled lower extremities, including the pelvis too. What is the E in evidence-based medicine? And then a little bit about regulatory capture. And then lastly, my hope for sort of the future directions that will happen for traction splinting. So before doing all that, I have to give you my own disclosures. It's kind of a longish list. I've changed this. I am no longer emergency medicine physician first. I haven't worked in an ER in 3 years. I'm really more of an inventor, tinkerer now. I still see patients in my community. I still prescribe antibiotics and stamp out urinary tract infections, but I haven't done trauma in 3 years. I've invented a variety of devices. I am a consultant chief medical officer for TriTech Forensics, and they own Hartwell Medical, Rescue Essentials, Sam Medical. In my past, and where I really started thinking about traction splints the most, was when I was an attending as well as resident at the University of New Mexico. I saw a lot more trauma back in that time. I spent about a decade developing a nonprofit called Endorphin Power Company. That's really a parallel life for me. And I've worked in many different places, lots of different ERs, and so it's shaped my take on the phrase standard of care. I think standard of care is very much shaped by where you're living and the types of tools that are available in those settings. The Donway traction splint has never entered my life in the United States, but it was all over the place in Australia and New Zealand. I worked for a short time in Haiti after the earthquake, about 2 weeks or so, and that shaped quite a bit of my thoughts on traction splinting as well. And nowadays, ever since 2012, I've been bringing product ideas and project ideas to Cal Poly biomedical engineering students. So that's sort of a fun side activity. All right. So, what do you think about traction splints? And people have been gunning for traction splints for almost as long as I can remember, and I think it's reasonable. That's why I decided to try to make them better in the late 90s. Is it an EMS relic? And a lot of people have said this to me. It's one of the least favorite skills aspects of EMS training. People don't love them. And I think it's a reasonable perspective. But why do we splint? And then I'm going to talk about traction as well. Why do we splint people? And at the end of the day, I think the main goal is to limit pain. You have bones moving like that, it hurts. If you keep them steady, it hurts less. Immobilizing fractures is a good thing. I think it stabilizes clots as well. If you've ever tried to glue two pieces of wood together or weld anything, it's just harder to hold it in place when it's moving. So you hold it together, keep it steady, clots can form. That, in theory, can reduce blood loss as well. I also view splints in general as a warning to other people. So, hey, that kid, they have a splint on them. Let's be nice to them. And then protecting from further injury. So this picture here, these are my kids. We were just doing splint training. They weren't both injured at the same time. But you can see, having those things on, you may be a little less likely to do flips in the trampoline. So why would I add traction to such a thing? And I think that this picture really explains quite a bit. Both of these femur fragments are like daggers. And if you have muscle surrounding those daggers, that muscle contracting shoves those daggers into tissue and it hurts quite a bit. And you have a vicious cycle. You have spasm, pain, spasm, pain. And if you can resist the spasm, you can relieve a lot of pain. Does it reduce blood loss? The NAEMSP would say we really don't have a lot of evidence for it, but I actually don't. It's not that I don't care. I don't think I'm ever going to know if it reduces blood loss more than just splinting alone. It's hard to differentiate those two. But it protects from further injury, facilitates transport, assists with fracture realignment. Some people will take a look at an x-ray and say, that didn't do a good job or that did a good job, but that really is a secondary objective of a traction splint. The goal is largely to limit pain. All right, so digging into the NAEMSP position statement itself, I'm going to read through these highlighted areas. EMS clinicians may use either static or traction splinting to immobilize suspected femur shaft fractures. And that's fair enough. Traction splinting carries contraindications, additional risks, and technical complexities that are not present with static splinting. So if I'm a new medic and I read this, when would I ever choose to do traction splinting? I'm going to static splint everybody if this is what I read. Static splinting may be the preferred method of immobilizing from midshaft femur fractures in the pre-hospital setting. So I think they were very close to saying static splinting is the preferred method, but for whatever reason they held off on that one. And then EMS clinicians should not use traction splints unless they have reliably assessed for and reasonably excluded the presence of distal femur fractures, knee joint disruption, and comorbid ipsilateral lower extremity or pelvic fractures. So this is, last nail in the coffin for traction splints from my vantage point here, because who has x-ray vision? I mean, why would a paramedic ever choose to traction splint after reading these 3 lines? I think it's problematic. So I'm going to split hairs. I'm going to go through different lines of the position statement. On page 3, so traction splinting has been associated with iatrogenic injuries. That is a true statement. So if you pull too hard, you can cause injury. If you have a crossbar underneath a fracture itself, that can be a fulcrum. That can make things worse. If you apply pressure, as the Sager does on the pelvis, on a broken pelvis, that can be a problem. But what is not included in the position statement is anything related to STSs. So they've been around for probably 15, 16 years now, and we've had no significant iatrogenic injuries reported. No one's even called me to say, hey, this hurt a patient. There is only one example from Australia. This thumb screw right here, after many uses, it protruded through and it dimpled the skin of a patient, and that got reported. And then we shortened the screw. So if you're using the original STS, that's a non-issue. The STS-C and Gen 2 don't even have thumb screws anymore. So, but it's hard. When things go well, people don't publish that. How would you know that the STS does not have iatrogenic injuries associated? On page 5, worldwide incidence of femoral shaft fractures ranges from 10 to 21 per 100,000 per year. That number doesn't actually help me one way or another. And why do we even say femoral shaft fractures? Patients don't say, I have a femoral shaft fracture, please help me. They say, I think I broke my leg. And for an STS, you should feel comfortable applying it to all of those patients because it's a splint first that just happens to offer traction. And I'm pretty sure a lot more people break their legs than people who show up with just isolated midshaft femur fractures. Rates of transfusion did not differ significantly in patients with various types of long bone fractures. So to me, that is dripping with selection bias. And it's also a retrospective analysis. To get that type of number, you look up in a record, you say, all right, let's find all the places where a traction splint was used, and let's see what the rates of transfusion were, and then extrapolate. But if you have 100 years worth of articles and you have contraindications to, okay, if I have a pelvis fracture as well as a femur fracture, I can't put the traction splint on, that's a patient who is more likely to need transfusion. And when someone is bleeding out, you're okay for a liter, but when you get to the end of 2 liters, things happen quickly. And so even if a little bit of traction limits the amount of bleeding, I think it's a good thing. I will say this: anybody who has managed somebody who has a broken femur, like those thighs are balloons. They swell up enormously, and it's not air in there. It's not urine, feces. It's blood, and the blood is not intravascular. And so I think it is still relevant. It's still important to manage those patients with both static as well as traction. But I'm never going to be able to know if static and traction offers more. That's a really hard thing to tease out. Identifying femoral shaft fractures and comorbid lower extremity and or pelvis fractures in the field can be challenging. That is an absolutely true statement. But with an STS, it's a non-issue. You don't have to have X-ray vision to apply these things in the field. You can put them onto patients who have pelvis fractures. You can put them onto patients who have distal femur fractures as well. Traction forces should be equivalent to 10% of body weight or not exceed 15 pounds, whatever is less. That to me is, that's absurd. So this comes from history though. So there was the Thomas traction splint followed by the Hare traction splint. The Sager came about in part in reaction to the Hare. And I think one of the benefits of the Sager is it taught us that, hey, it doesn't actually take very much traction to make people feel better. There's a gauge at the end, and you can see that no more than 15 pounds is necessary to make people feel better. But to ask medics, all right, what is the weight of this patient now? Multiply by 10%, and it's absurd. Treat the patient, not the numbers. Pull traction until the patient says, I feel better. All right, unfortunately, traction splints may loosen over time. It's not unfortunate. That's what they do. So you apply traction to a spasmed leg, and the muscles relax, and it loosens. And that's how it is. So by the time patients come to emergency departments, often it will look like the traction splint is actually wearing the patient. It may seem loose. And you ask the patient, is this uncomfortable? No, it's okay. Leave it there. You don't have to add more traction. As long as the patient says, I feel better, and the leg is straight, mission accomplished. It's not unfortunate. And then long devices may present challenges when packaging patients. That's correct. Many devices stick out past the leg. The STS, all 3 of them don't stick out past the leg. So they're really good in any tight spaces. In the Stokes basket, aeromedical use, it's nice that it doesn't stick out anywhere past the leg. The application of traction splints can also increase time on scene. So this may be coming through in a choppy way for you here, but I'm pretty sure that I can put a traction splint or an STS onto your leg faster than you can draw up a vial of fentanyl or morphine. I'm certain I can do this faster than you can static splint your patient too. This takes less than, if you practice, you can get it less than 30 seconds. I can certainly do it in less than a minute. All right, so just what else was in that position statement, as well as the meta-analysis? If you do a control find for Slishman on there, this is the only mention of it, and it's just in the references. There's no other mention of it throughout. And this is the article. So Slishman Traction Splint had the best objective performance during testing and the highest subjective evaluation by participants. So that's a pretty nice article from 2014, but it's really not talked about in the rest of the position statement. An article that did not make the cut in the position statement is this one in GEMS from 2023. So New York City Fire Department has been using STSs for, I think, well over 5 years now, and I think they've been happy with them. Their assessment after this article is basically educate people, train more, and increase the use of traction. So they're not discussing getting rid of traction. They're discussing how do we get people to use it more. All right, so that's enough on the NAEMSP position statement. They did a similar treatment for pelvic binders as well. I'm not as expert. I haven't been spending decades thinking about pelvic binders, but they have a similar perspective. In both of these analyses, though, if you do Control F for pain, Control F for comfort, it's a big gap. There's not a whole lot said in either paper regarding that. And I think that's problematic. In reality, now this here is the, what do you call it, the worst form of evidence. So social media, N of 1, a single post, but I'm still going to read it to you anyway. I broke my femur snowboarding in 2014. They applied a Hare traction splint. Holy hell did it hurt, but once traction was pulled, the relief was better than any pain meds I could have gotten. Ski patrol pulled traction, the ambulance pulled more traction, ER did x-rays, and I still had bone over bone, but the relief was there. The nurses wanted to take the traction splint off and put me in the hospital splint. Thank God my dad stepped in and did not let anybody touch that splint. They left me in that splint overnight and into surgery. And that is a story that I hear over and over again from people who have had broken femurs. Traction helps. All right, so this is a long slide. I'm not going to run you through all of it, but these are different ways to address pain when it comes to broken legs, but also other problems as well. So if you're in an austere setting, you have oral meds, then you can use those, but folks don't love using oral meds if they're about to go to the operating room. Fentanyl lollipops are, I think, a great thing, but apparently I just discovered that they're no longer making them. So a bit of a bummer there. IV medications, IO, IM meds, probably the top two are fentanyl and ketamine. Fentanyl I've used, that's been my go-to narcotic for a lot of different orthopedic trauma through the years. Ketamine less so, but I see it being used more and more in the pre-hospital setting. It definitely has its downsides. When I was in New Zealand, I had a chance, and I also saw other people doing this, femoral nerve blocks. Somewhat hit and miss. If you're good at it, then great. But it can cause discomfort. If you hit the wrong things, it can cause a little bit of bleeding in there, and it takes a little bit of time as well. There's, nitrous oxide. To be honest, I've never used it for this setting, but everybody loves nitrous oxide. Intubation, if you want someone to stop screaming, then that's one approach, but there are plenty of downsides with intubation. But the lowest hanging fruit, not even talking about devices here, is manual traction. So if you have somebody who you think they have a broken leg, just hold their leg and apply gentle manual traction, and you'll know if a traction splint is going to be helpful or not. If that manual traction gives relief, if the patient says, okay, hold there, don't move, do not move, stay right there, then there's a good chance that an STS is going to be a helpful step. So I actually view there's a parallel product line out there, the junctional tourniquets. If somebody has bleeding from their groin, from a femoral artery, you put direct pressure on it, you pack it, put pressure with your hand, and you maintain that pressure. But if you're still being shot at, if you got to drive the vehicle, if you have to write some notes, do other things, then a junctional tourniquet to maintain pressure makes sense. It's a little bit similar here. Manual traction is a good thing, but can I hold manual traction all the way to the hospital? That's a little hard, so get me a traction splint. You can do static splinting if you want, but that also takes time, and they can be pretty bulky. It takes time to do them well. And if you have bone over bone, you still may have a lot of spasm and pain. STSs, I'm going to run you through a lot of the pluses. So for me anyway, they are quick to apply. They allow easy circulation sensation motor assessment. You can examine the perineum pretty easily. Easy to adjust and readjust. So I'll put the cord into a patient's hand and say, look, if you want more traction, you can pull more traction. That's okay. If I'm not in the room, it's not a bad thing. This is not rocket science. You pull if it feels better. So patients can participate. It's actually easy to log roll patients, x-ray transfers. You can do rectal exams, Foley exams. I rack my brain trying to come up with minuses, and it's hard. I know I'm very biased, but it's hard coming up with minuses for using an STS on somebody who says, I think I broke my leg. And something I also want to mention for pain control, soothing conversation, being nice and calm is a helpful thing. I have diminished a lot of pain with YouTube videos as well. So I'm not sure if there will be a meta-analysis on that though. So let's get a little meta, as Mark Zuckerberg might say. So evidence-based medicine comes in a lot of different forms. And I think people who really are religious about it, they say, I practice evidence-based medicine. What they really mean is, I want to practice literature-based medicine. So in that realm are these things here. You've got testimonials, case reports, abstracts. Meta-analyses, I remember back in the day thinking that is the best form of evidence. That has to be wonderful. Randomized double-blind prospective trials are wonderful as well, but they're hard. A meta-analysis it almost looks like you're looking at everything. You have a bird's eye view, and that's going to be the best of the best. But it has its flaws. In reality, there's a lot of literature out there. I think for myself, most of my medical practice has come from all of this here. So, personal experience, you've got these n equals 1, n equals many patients. For me right now, I've applied STSs to many people at this point over the past few decades. So that has shaped my take on traction splinting more than any article that's been written. I've done a lot of experiments on it. I put Hard Knocks University here too, because if you miss an ankle fracture and you get sued over that, there's a high probability that no matter what those Ottawa ankle rules are, you're going to be x-raying everybody with a sore ankle for quite a long time after that. So that shapes how a lot of people practice, I think. Other people-based medicine is, I think, what drives a lot of decision-making too. So you ask your colleagues, what do you think about this or that? I read a lot of textbooks in medical school and residency. That shaped a lot of my practice as well. Podcasts, EM abstracts was a big one in my life. Now social media and webinars, that shapes a lot of how we behave as well. But the AI is like this new realm of evidence-based medicine, which is, I also call it amplified idiocy too sometimes. Because if you ask AI, what's your favorite traction splint, it will give you some really remarkable answers. So actually, did anybody here see the African Queen? So my take on AI is people are enjoying it. There's this scene where Katharine Hepburn and Humphrey Bogart are floating down the river. Things are happy, and then they hear this waterfall in the distance. That's how I feel about AI right now. I don't know when we're going to take the big tumble, but there's more and more noise, and it feels scary to me. Anyway, the project that I wish, if I had residents and medical students at my fingertips, I would love for somebody to do a meta-analysis of meta-analyses. And this is my hypothesis going in. So the vast majority of these papers are based on other papers that are largely retrospective, just because prospective articles are harder to do, so you have fewer of them. There's a lot more objective types of papers as well in meta-analyses, as well as numerical. And that's why you see things that are, rates of transfusion. That's numerical, that how many different units of blood were needed. Subjective, qualitative things are a lot harder to do. It's hard to do a pain study. You can't be like, let's separate half the patients into Sager traction splint and half into Hare traction splint and see who feels more pain. It's an impossible study. You're going to have a lot more older studies as well versus recent. In meta-analyses, you see publications. You don't get these, thousands of different testimonials that are all over the internet saying traction helps. You're just going to see publications. And then also monolingual versus multilingual. So it's wild to me to think that this conversation may be happening in China, as well as Ghana, as well as Brazil. And all of these, there may be meta-analyses on all of these things, but they don't know about each other. Negatives versus positives. You'll see a lot more negatives in meta-analyses because those things get published. If I put a C-collar on somebody and their head pops off, that is going to land in an article. If I have 10 or 20 years of traction splint applications and nothing bad happens, that doesn't get into a meta-analysis. When I think about any medical device, I separate it into, is this thing a life-saving device or life-improving? And then what's the harm potential of it? And when I say life-improving, is it something that it diminishes pain, it diminishes anxiety, fear, does it add comfort? So I'm going to run through all of these here. So Band-Aids and slings, are they life-saving? Not particularly, but are they life-improving? Absolutely. I've gone through probably hundreds, if not, probably not thousands, but of Band-Aids. My kids just churn through them, and it helps them without a doubt. Is there harm potential with these things? It's very, very low, and that's why you can find them at Target and Walmart and everywhere. AEDs are on the opposite side of the spectrum. Are they life-saving? Absolutely. I had an experience with them after an adventure race recently, and it changed my take on AEDs completely. It's a remarkable thing. They can save lives. Do they diminish pain? No, that's not part of what they do. But they also have very low harm potential. That's why you can see them in airports and all over the place. It's hard to really hurt people with AEDs. On tourniquets, and I hope I don't wind people up on this, I have posted a lot of things on tourniquets over the years, and this really captures my thoughts on them. So they are life-saving devices, and I understand it why tourniquets they enter the realm of religion. People get very passionate on this. If you or somebody else is bleeding out, and you put this tourniquet on, you crank that lever and you see bleeding stop, you are going to want to sing about tourniquets from the hills. You want to get these into the hands of everybody. And that makes sense. Do they offer comfort? No, they hurt. It really is quite painful. But here's the kicker. If you put tourniquets on wrong, then you can actually amplify blood loss. And I don't think that is common knowledge. And so I've been trying to get people to understand that more and more over time. I don't know if I'm successful with that, but still working on it. Binders and traction splints, I've talked about this already to some extent. I put question marks here largely because of these NAEMSP statements. I think they are both life-saving. I think that binders probably are more so than traction splints because a crushed pelvis is a very bad thing. And if you pull those parts back together again, I think you will bleed less into your pelvis. Do binders lead to less pain? I'm actually not sure. I have not put enough on to really have a strong opinion on that, and I don't think the literature really shows it very well either. But I've heard from plenty of people that I put that binder on, patient said I felt better. That's good. Is there harm potential with binders? There is. If you put it too high and you have crushed iliac crests, you can make things worse. If you have a femoral neck fracture, that can make things worse. So if you're going to use a pelvic binder, good to use it right. With traction splints, in a similar way, do they save lives? I think they do. They absolutely 100% diminish pain. Like I have no doubt on that one at all. When I say, it depends with harm potential, it depends on which ones you use. So I think the harm potential with STSs is very, very low. Splints, life-saving. If they're stabilizing clots, I think they're actually saving lives too. They absolutely limit pain. Not a whole lot of harm potential with splints. Wraps, I love wraps. I love all types of wraps. And the reason is I can stop bleeding, I can do so many different things with it, and I can offer comfort with them as well. And the main ways that I can hurt people with wraps is by strangling people. So that's no good. You can put them on so tight that they don't have perfusion. You can lose limbs in the same way that you can lose limbs if you have them on too long with tourniquets too. But I think it's harder to hurt people with wraps than it is with tourniquets. Chest seals. So I will say I have been chest seal ambivalent through the years. There are many different types, and I struggle. I've never had to put one on in a bad setting. So I'm not the person to be talking about them much, but I can say that on a physics level, there is very little suck in a sucking chest wound. It is only, if you want to simulate a sucking chest wound, put your hand over your mouth, like that's the amount of suck there is. So it's not much. So what I fear more is actually the tension pneumothorax. So you put a chest seal on somebody and you have air going through the mouth, out the lungs, through into the space, creating a tension pneumothorax, that's no good. So if I have to choose, I will choose a vented chest seal, but I'm not an expert on chest seals. I should say all of this is just my own rubric, my own way of looking at different devices. This is not how you have to think about it, but it's a way of thinking. C-collars and backboards, I think they actually can be life-saving in the sense of splinting. But it really all depends on how life-improving, harm potential. Like if you leave people on these hard backboards for a long time, that can be painful. To some extent, I feel like people have treated C-collars and backboards poorly. I meet folks who say C-collars and backboards are going away, and they're almost leading the charge ahead of binders and traction splints. But I just think I think it's kooky. If you don't like C-collars, if you don't like backboards, then make them better. I mean, there are so many different types of C-collars too. You got the hard collars, the Philly collar, inflatable, the vacuum collar. It's just a lot of different ways to do it. If you want to make them better, add some earbuds, give people a little bit of music, add some warming or cooling elements in it. Backboards, why don't we make these things padded? There's so many ways to make these things better. Why just say, oh, we don't need these things anymore? It's kooky. And then I throw this line in here, the toilet seats. So the evolution of toilet seats, and I'm not sure, I'm not a historian in this realm, but probably toilets were invented first without the seat. And people were like, this is great. This is a wonderful thing. And then the next step is people sat on them for a prolonged period and read magazines. And then they discovered they stood up and couldn't feel their legs anymore. So let's add a toilet seat. And now we have comfort and we don't have to sit on our preteens urine. Wonderful things about toilet seats, but imagine if a meta-analysis came out and they said, look, we have analyzed all of the research related to toilet seats, and we found no evidence showing that with or without a toilet seat, there is less paresthesias in your leg. Therefore, we don't need it anymore. That is kooky. But that's how I feel about the assessment of traction splints right now. Like toilet seats are there for comfort. They're there to make life better. Moving on, I'm going to dig into traction splints now and just go through legacy traction splints in particular. These are the two that led me to think about this back in the late 90s. So they're quite challenging. This is the Hare, that's the Sager. They're challenging to apply, especially in confined spaces. There are all of these different parts, all of these different steps. Traction from the foot is a different thing than traction from the hip. Traction from the foot is, I'm going to do this to you, as opposed to traction from the hip, where I'm going to do this with you. There are all kinds of contraindications associated with these. They're very bulky. They're overbuilt. This strap here with the Hare traction splint, you could lift a car off the ground with it. It's unnecessary. All of this is steel. All of that is unnecessary. And they take a long time to put on and to adjust. You have parts that can go missing. I've worked in a hospital where they had 3 different bags. One of them was a pediatric Hare, another was an adult Hare, and another one was a bag of parts stored in a Sager splint bag. And it's kind of a mess. Why have a pediatric version of this as well? Both of these have pediatric and adult versions, and that gets into protocols too, which is just mind-blowing to me. They're radio opaque, so people will take them off in order to get a better quality x-ray. I've seen patients, they've had more pain related to these things than patients come in with. And so I just think that both of these types of traction splints are, well, I don't love them. Pressure points, they're expensive. So Slishman Traction Splints are just a very different animal. They're easy to apply. It takes less than a minute to put them on. One size fits everybody. It's a single connected device. The Gen 2 and the C, the ankle and the groin strap, they are tied to the bar itself, so you're not going to lose it. When you pull it out of the bag, you're not going to have that embarrassing moment of, oh, geez, I don't have my ankle hitch anymore. And there's no extension past the foot. Just a lot of different reasons to be using that instead. All right, getting clinical again here. So femur fractures basically land into 3 different categories here. So probably the most common is the isolated femur, and the patient is conscious and screaming. And that's what we think of the most. You want to limit pain in that patient. Patient who gets hit by a car, they're unconscious and flaccid, that's a different animal. They don't need traction, they need more splinting. And then there are patients who are something in between. They're groaning, they're miserable, and they also have a broken femur. So I've had examples of all of these. So this is the very first person that ever had any version of one of my traction splints applied. This was a guy in New Zealand. He was actually a lawyer, and he had a Hare traction splint on his leg, brought in by ambulance, and he was howling. He was waking up the whole emergency department and absolutely miserable. And I'll admit, I was young and naive. I had my ski pole prototype, and I said, look, can we try this other thing? And I think he said, anything, whatever it is, I just want this other thing off of me. We put on my ski pole traction splint, and he felt immediate pain relief. This is a picture of him and his wife. They're both smiling, but I blurred their faces. It worked, and so that made me think, maybe we're onto something. On the other end of the spectrum, this is a guy who was in a motorcycle wreck, and he showed up intubated. Like, there wasn't a whole lot of, it was not pain that we were addressing here. I remember they brought in fragments of his bone. So he took a turn, wrapped his leg around a street sign, and all kinds of problems here. So what do you do in this case? This is a patient where you can't put a Hare traction splint on because his ankle is a mess. So we splinted his ankle and put the ski pole version over him. And the orthopedist was happy with the level of splinting. They went to the operating room. But in this case, this is not someone who needs traction. There are all sorts of things that are in between. This is a patient back in New Zealand again. I took this picture because they had bilateral femur fractures. They had other things going on up here, some tummy problems. And, but the photo I took largely just to capture the absurdity. It's very hard to examine the foot here. This kickstand is, if that falls off the edge, that's no good. So imagine trying to roll a patient like this, just hard. This is another patient from New Zealand. They had bilateral femur fractures. This is what one of my earlier prototypes looked like, and it's a pretty well tractioned leg. It's nice and straightened out here. And this really shows what bilateral femur fractures look like. They're really grossly externally rotated. All right, so this here captures my take on managing people who have been injured in many ways from their waist on down. To me, the crushed pelvis is still the most life-threatening thing, so that should be addressed first. In summary, I take a top-down approach. Crushed pelvis, hypotensive concerning mechanism, deal with the pelvis first. I've changed this a little bit. I said bind the feet, because that is a useful step no matter what, and it's really easy to do. Add a pelvic binder if you like, and then move down to, I suspect, a femur fracture. Yes, STS, you can use it with or without traction. If there is injury from the knee on down, splint those things as well. Splint on scene or splint down here, en route. But one of the most important things to consider here is STSs can be used despite concurrent pelvis injuries. All right, just a couple more words on holding the feet together. So this, I feel like, a picture is worth 1,000 words. This is a patient who basically has their feet out, and when you rotate them in, you can see it pulls the pelvis together. So it's a good thing. The Slishman pressure wrap is included with the STSC and the Gen 2, mainly for rotational stability, but it's also helpful if you have a crushed pelvis. All right, people will ask me, what does it look like? Can I combine a pelvic binder with an STS? The answer is yes, this is what it looks like, but most important, put the binder on first and make sure the binder sits over the greater trochanters. Back to that NAEMSP paper, you don't have to choose. It's static versus traction. With an STS, they work together. You can put an STS on and then do static splinting as well over it. This was in Jackson Hole. They use, ski patrollers love these box splints, but they work together. How well do they work on kids? Just fine, but you don't need as much traction on kids. It's mostly splinting for kids. What about for tall people? So if you have somebody who is 7 feet or 8 feet tall, just go proximal to the calf, and that will suffice. Some people will ask me, is it all right to apply pressure to that spot? There's the superficial or perineal nerve there, and you risk foot drop. So if you have too much pressure on that spot, we've had no reports of foot drop from that. And I think the reason is you apply it, and then after spasm goes away, there's less tension on that spot, less pressure on that spot too. Also, that type of neoprene, you can't cinch it. Once it's applied, you can't cinch it. So it's really hard to make that too tight. All right, how long can they be left on? There's no clear limit on that. When I went to Haiti, I think I had one of these splints on a patient for 10 days. And it was nice because they had a little bit of mobility in the bed while they were waiting to go to the operating room. And when I got there, many patients had basically sand buckets dangling from their feet. So they didn't love that. All right, all the different contraindications that you may think of with traction splinting, they don't apply. The Thomas, Hare, Reel, Donway, they all have these crossbars that sit under the proximal femur. That's why we say you can't use a traction splint on patients with proximal femur fractures. But that's a non-topic for an STS because this is what the strap looks like. It's no problem to apply it there. I've actually put these on to patients who had hip fractures as well. It's okay. Oh yeah, there is one caveat here. So open or closed fracture, if you have someone who has an open fracture, I split those into 2 groups. There's damaged skin and I suspect a femur fracture. Go ahead and splint or apply traction as you would. But if you have an open fracture where bone is sticking out and dripping with mud, probably don't pull that mud back into the body. That's suboptimal, I think. All right, what about distal femur fractures? So this is a patient I had in King City. They fell in a gas station nearby, landed on their knee. Distal femur fracture, not a problem. Put the traction splint on, they felt better. It worked out just fine. How about hardware? If a patient says to you, I have a prosthetic hip, would you be reluctant to apply a traction splint? It's a non-issue. You put the STS on, you can splint them. If a little bit of traction helps, so be it. This x-ray was sent to me from somebody out in Europe too. There's nobody who has published on this, but you can use STSs on a broken humerus as well. Are they radiolucent? That question comes up sometimes, and the answer is, what I say is it's relatively radiolucent. So you can send it through an x-ray and CT, and it doesn't obscure the view of fractures, and so you can leave it on without a problem, but you can still see it, so it's not truly radiolucent. The only thing that's really radiolucent is outer space. And then also for MRI, there are this here, the spring button, the screws, those are ferrous, so you can't do an MRI with current versions of STSs. All right, I did a training for some ski patrollers a few years ago, and I learned something from them. Up until then, I thought, well, manual traction first, then apply the splint, but they basically wrapped one of their patrollers around a tree and put the splint on first, and then applied manual traction while applying traction with the splint. So I don't think you have to say manual traction first anymore with STSs. This is a longish slide, but all of these objective differences between traction splints, you can verify. You don't need a meta-analysis to assess this. Take a screenshot if you'd like of this. But I'm going to pull your attention to these 2 points down here. So a Sager is useful for bilateral femur fractures, and that is true. But if it costs 2 to 3 times as much, buy 2 STSs if you really care about bilateral femur fractures. Also, the Sager and the Donway have mechanisms to assess how much traction is being applied, and that segues to the phrase of the day, which is regulatory capture. So in Canada right now, years ago, in Ontario in particular, they developed protocols that I think were influenced by the Sager. In the protocols, it said traction splints have to have quantifiable traction. As a result, in Canada, you have to pay, I think it's somewhere around 1,200, 1,300 Canadian dollars for a Sager traction splint. That's the definition of regulatory capture. And I have, for quite a while, wanted that to go away because I'm a treat the patient, not the numbers guy. So I am now making these. This is like a fish scale, and you can attach it to the toggle. You can pull, and when it bottoms out at 15 pounds or 7 kilograms, you know that is probably more than you need. So if anybody out there feels like, I would love to use an STS, however, I need quantifiable traction, you give me a call. I will happily send you one. Future direction of traction, I think I broke my leg. STS should be okay. I would love it for EMS physicians, ER docs, radiologists, orthopedists to collaborate and actually decide, hey, this is a reasonable thing. Let's put a traction splint on at the point of injury, leave it on all the way to the operating room. Every step in between is a painful step. I'd love it if there were 5 packs of STSs in the ER so that when paramedics come in, they don't have to wait around to get their traction splint back. Just pick one up from the ER. I would love it if skeletal traction went away. I don't see any reason for it. I'd love to see if traction being used for chronic pain. This is reiterating some of those points. Each of these is a painful step. When a patient gets brought in with a traction splint, sometimes ER docs will take it off, and that hurts. And then sometimes things get removed just to get X-rays. Sometimes orthopedists will come around and change the traction splint again. And every step is painful. The world I want to live in is STS gets applied here and it's left on all the way to the operating room. This is, I have these pictures from skeletal traction examples. This is from India. But people are still doing this. They will drill through perfectly good bone to dangle weight to offer traction. It makes no sense to me. You can apply this STS here and have traction as well. I know a number of people have told me that they are using it for chronic knee and hip pain. I'm not sure if it will work regularly for folks, but it's something that I think deserves research. Some parting thoughts for the NAEMSP. No hard feelings. I think you've done a great analysis for, well, frankly, obsolete medical gear. I wish that some of that research energy would be put into some of the things that I'm saying here, and maybe things will change in the future. But please don't throw the baby out with the bathwater. And then all of my protocols, if I ever was an EMS physician, all of my protocols would be shaped by these things here. So treat others as you want to be treated. If I have a broken femur, I want a traction splint. And pain very much matters, in my opinion. Okay, so thanks everybody for enduring that. And if anybody has questions, you can add it to the chat.